Ladies and gentlemen, welcome to our global live webinar celebrating a remarkable milestone. 10 years of innovation, dedication, and success with FTRD. Over the past decade, FTRD has transformed interventional endoscopy, empowered users, and set new standards in excellence. Today, we gather to reflect on this journey, share inspiring stories and experiences, and look forward to an exciting future ahead. Thank you for joining us in this celebration of a decade of achievements and the new horizons yet to come. I would like to introduce the board of speakers in the order of their appearance in the webinar. My name is Bettina Stritzke and I am the Director of Product Management at Ovesco Endoscopy AG, based in Tübingen, Germany. I can further welcome Professor Karel Caca, Medical Director of the Department of Internal Medicine at the hospital in Ludwigsburg in Germany. Dr. Gregory Haber, Chief of Endoscopy and Director of Advanced Therapeutics and Innovation Division of Gastroenterology at NYU Langone Medical Center, New York, United States. Dr. Zahir Nabi, Consultant Gastroenterologist and Director of Interventional Endoscopy at the Asian Institute of Gastroenterology, AIG, in Hyderabad, India. Dr. Philip G., Associate Professor of Advanced Endoscopy at the University of Texas, MD Anderson Cancer Center in Houston, Texas, United States. And last but certainly not least, Dr. Barbara Bastiansen, gastroenterologist at the Amsterdam University Medical Center in the Netherlands. Thanks for being part of this live session. I'm looking forward to hearing more about your experiences and insights. Please note that the presentations in this webinar have been pre-recorded to minimize any technical disturbances. You are invited to submit your questions using the Q&A function in Zoom. We will address them during our dedicated Q&A sessions throughout the webinar. The first short presentation from the Ovesco perspective shall give you a brief recap of the past decade with FTRD. So let's get started.
Hello everyone again from my side. I would like to take the moment to take you on a little journey looking back at a decade of FTRD, how it all started, where do we stand today, and what happened in 10 years. It basically all started with the TEM procedure, which was pioneered by Gerhard Bues in the 1980s. It has become an established concept of full-thickness resection for the removal of lesions from the rectus sigmoid using a rigid endoscopic system. However, this technique had its limitations with regards to using it in certain localizations and in flexible endoscopy. The second concept we're looking at is the Ovesco OTC clip, which was introduced in 2008 and since then successfully used for effective tissue closure. So we from Ovesco combined those two concepts, coming up with the FTRD, which is a modified OTC system with a longer cap, a modified clip, and an integrated snare for tissue resection for the use in flexible endoscopy. It is the first interventional system for combined full-thickness resection with closure and cutting of the tissue in one integrated procedure. So we always first safely clip, and then we cut the tissue. Introduced FTRD in November 2014 as the FTRD system set. 2 years later, we changed its name to colonic FTRD as we already had further variants in development. We also introduced the Prof cap, which is a dummy cap that you can use to check whether you can actually use the FTRD device in a certain localization. 2 years later, in 2018, we introduced the duodenal and the diagnostic FTRD set, the first one being used in the upper GI, specifically in the duodenum, the latter one in the colorectum, if you need to gather full-thickness biopsies, in case you maybe have suspicion of a motility disorder or the like. In the consecutive year, we changed the name from duodenal to gastroduodenal FTRD as we extended its range of application to the stomach as well. We also introduced the corresponding Prof cap, so here again you can check the usability of the device in that location. 10 years later, we have an entire product family, and we can ask us what is yet to come, and we may be able to answer part of the question today in the webinar. FTRD originated in Germany and it spread across the globe from there. After 10 years, it is being used in more than 80 countries in the world, and over 55,000 procedures have been performed. The FTRD today is not as it was 10 years ago because we from Ovesco continuously strive for product enhancement. So we extended its range to new indications and localizations. We've facilitated its assembly and also its insertion by using different materials and modifying parts of the product. We've improved the snare cutting performance by modifying the HF settings and also using new materials. We've improved snare closure by using different materials and modifying the FTRD cap geometry. And we've also optimized clip application by implementing the brown loop mechanism. And one thing you can be sure of that we are working on more, so stay tuned and see what's coming next. FTRD today can be considered well established in clinical routine. It is a well-studied procedure with over 7,000 patients subject of clinical trials, over 130 papers published. It has generated high technical success and are zero resection rates and also low rates of adverse events and no AE-related mortality. It is a relatively simple procedure that requires less training compared to other advanced resection techniques, which led to a rapid integration into clinical routine. However, FTRD practitioners should be capable of managing potential AEs and have prior experience performing endoscopic resection techniques. Therefore, the former preclinical training is a must for the proper and safe use of FTRD. We can conclude that EFTR with FTRD is a highly effective and safe method for treating difficult to resect lesions not amenable to conventional endoscopic techniques, providing a minimally invasive alternative to traditional surgical methods. I would like to conclude my short presentation with showing you a little video that nicely shows the successful history of FTRD.
The FTRD system is celebrating its 10th anniversary. 10 years ago, the colonic FTRD system was launched. Developed to enable endoscopic full-thickness resection, previously only possible by surgery, it has fundamentally changed endoscopic treatment. Over the past decade, the FTRD system has gained worldwide recognition. It has helped countless patients by providing a less invasive alternative to surgery. Numerous studies have proven its efficacy and safety. Comprehensive training and courses at the Ovesco training campus are an essential part of our success. Through targeted training, we ensure that the FTRD system is used safely and effectively worldwide. But our journey is far from over. We continuously work to further develop the FTRD system and explore new applications. Thank you to everyone who's been with us on this journey. Here's to the next 10 years of innovation and success.
Well, there's not much more to add. Then thanks to all of you for being part of the journey, and please continue being part of it. I thank you for your attention. I'm happy to answer any questions that may come up. And now back to the group.
Well, now let's delve deeper into the clinical profile of FTRD after a decade of remarkable advancements. We are truly honored to have Professor Caca with us today. As the very first user of FTRD and an unparalleled expert in this field, he has been at the forefront of its development and application. His extensive experience and profound knowledge make him exceptionally qualified to present the state-of-the-art developments. So please join me in welcoming Professor Caca to share his valuable insights.
Dear ladies and gentlemen, it's a great honor for me to give the state-of-the-art presentation of a decade of FTRD. We are very proud that we were involved from the very beginning, from the developmental establishment, the clinical establishment of the technique. The OTS clip was thought in the beginning as just another clip, but it proved to be much more. Nowadays, we have indication for the clip for endoscopic hemostasis, for perforation closure, for fistula closure. We have a special device for stent clip fixation, for bariatric reduction, and what's the most important for the full thickness resection. Full thickness resection with the FTRD system is named Neo-EFTR. That means it's a non-exposure technique. We don't open the GI wall. We make a wall duplication first, so the defect closure before resection, and then we resect the specimen. So it means clip first, cut later. The first publication was 10 years ago, done by our group, and a patient with a recurrent adenoma. He already had 2 times EMR, and it was very scarred. It had a non-lifting sign. And as you can see here, after application and resection, you can see nicely the wall duplication, you can see the peritoneal fat, and you can see the OTS clip. This is the resection specimen, and for the pathologist, very convenient, he has a full thickness resection specimen. He can see nicely here the normal epithelial lining, here the adenoma, here the submucosal space, here the muscularis propria, and here the peritoneal fat. So let's start with the FTRD in the lower GI tract, which is the more important indication. There's been 3 big studies published, one prospective multi-center study from the German groups with 8 different centers, and 2 national registries, one from Germany with nearly 1,200 patients, and one from the Netherlands with 367 patients included. And as you can see, the results are very comparable. We have a technical success rate from 85 to 90% about. We have a R0 resection rate about in the 80s, and we have severe adverse events only about 2 to 2.7%. So this means severe adverse events means need for surgery. And we have a 0 mortality rate, so there's no mortality, which is very important for the patients. So let's come to the results. Only just to show you a little bit of the results. So since I think most of you are familiar with the results, this was the wall resect study, and you can see the inclusion criteria. So what we are dealing is in 57% with adenomas with a negative lifting sign, either recurrent or untreated. We have adenomas at difficult locations, most importantly at the appendical orifice. We have T1 carcinomas with indication for endoscopic resection or re-resection in 8%, and we have subepithelial tumors, mostly of them rectal neuroendocrine tumors, 13%. And the results were, as you can see, the location was in 50% of the right side of the colon, and the lesions were reached in 100%, and the technical success rate was 90%. So every lesion could be reached, although the centers were not extremely experienced at the beginning of this trial, and the technical success rate of 90%. The R0 resection rate was 77%, and it came down to 58% if the size of the lesion was larger than 2 centimeters. Serious adverse events, as already mentioned, 2.2%. And from a different other study, the risk of an appendicitis after resection of the appendical orifice is 14%. So this is something you have to discuss with your patients. The half of them need surgery, half of them can be treated with antibiotics only. A very important publication was from the Dutch group, and I think Dr. Bastiansson will speak later on about their results. You can see, if you look at the T1 colorectal cancers, if you apply the harsh critics of low risk, including the infiltration depth, you end up only curative in 20%. But if you do an extensive definition of low risk, that means not infiltration depth as a single criteria, you end up with 60% of R0 resected T1 carcinomas. And this is a big difference. This is a big difference for the patients. If they have a low risk colorectal cancer, they can be resected endoscopically and no need for surgery. Now, coming to the big guys. If you have something like this, a lateral spreading lesion, and you want to resect it, most of them are benign. There's no need for ESD in this situation, but you cannot achieve it with FTRD because it's too big, and most of it you end up with piecemeal EMR, and suddenly you encounter a region where there's a non-lifting sign, you cannot proceed with your EMR, so then you can switch to FTRD. And our recent publication last year was on 75 patients. The mean lesion size was 3.6.5 centimeters, and you do a EMR as much as possible, and the part that is non-lifting you remove with FTRD in the same sessions. Procedure time 84 minutes. The technical success rate is 100%. The adverse events 6.7, severe adverse events 1, appendicitis needing appendectomy 1.3%, T1 carcinoma 16%, 5% low risk, 11% high risk. And the follow-up, we had recurrent residual adenomas in 8% of the patients. We could remove them all with a redo FTRD in 10% and with a redo EMR in 1%. So these are very good results from my point of view. What's also a very good indication in the lower GI tract are the rectal neuroendocrine tumors. We published this already in 2020, 40 patients, and it's a straightforward procedure. You're done in 23 minutes. You do a macroscopic complete resection in 100%. You have a full thickness resection specimens in 95%, and you have a very, very low complication rate. You have only peri-interventional bleeding during the procedure, treated endoscopically. You have maybe some technical problems, 2.5% because of rupture of the snare. That happens very rarely. So this is the way to go. You have a rectal net. So let's conclude for the lower GI tract. I think we've come a long way. Nowadays we can resect endoscopically nearly all of the benign colorectal lesions. We are aiming for complete resection, but that doesn't mean always an en bloc resection. We can be happy with a piecemeal EMR. And so the FTRD EFTR closed a major therapeutic gap from my point of view, and the hybrid EMR FTRD is closing a small but important therapeutic gap, but just as a logical next step when you're in trouble, you cannot complete your piecemeal EMR and are looking for a different technique. So sometimes, however, EFTR is only a large biopsy. If you end up with a high-risk lesion, high-risk T1 cancer, then it's diagnostic and not therapeutic, and you still need the surgeon. So nowadays, when in doubt in the lower GI tract, take it out to nearly 100% endoscopically. Now coming to the upper GI tract. After establishing FTRD in the lower GI tract, the company came up with a special gastroduodenal FTRD system for the upper GI tract, because the FTRD system for the lower GI tract was a little bit larger and it was more cumbersome, the passage of the upper esophageal sphincter, and it comes also with a balloon for a better passage of the upper esophageal sphincter and the pylorus. So when do we need full thickness resection in the upper GI tract? In the esophagus, it's difficult and nearly not applicable. However, in the stomach, we have wonderful EMR and ESD. We need it for the subepithelial lesions. For the subepithelial lesions, we need a full thickness resection device. But in the duodenum, it's a bit different. There we have the subepithelial lesions, and then we have these non-lifting adenomas, maybe after a previous resection, the non-lifting signs, and maybe as a first-line indication there. There's a meta-analysis being published this year, and you can see there are 8 studies, 3 of them are from our group, and you can see the technical success rate is a little bit lower than with the lower GI tract, because it's not always successful passage of the pylorus. The pylorus is really the gatekeeper for access to the duodenum. So 82%, the R0 resection rate also a little bit lower, 70.7%. And adverse events, 22.1%, 18.6% minor, no severe adverse events, no need for surgery in these publications. And the recurrent residual lesions found after up to 1 year follow-up time was 6.1 90%. Going a little bit more into the depth, if we are looking at the gastric cysts, that's what we want to resect. If we want to resect something, we want to resect in the stomach the gastrointestinal tumors. But however, we can resect them only up to a size of maybe 1.2 to 1.5 centimeters. Otherwise, the cap is too small. And we've done a study in 29 patients. It's a straightforward procedure. The passage of the upper esophageal sphincter is nearly always possible. Technical success rate 90%, R0 resection rate 76%, for thickness 65%. We had only minor adverse events. And however, what you end up is, you end up still with 34% of ectopic pancreas, and the lesions you are looking for, the cysts and the nets, are also only about 1/3 of the lesions. So this is mostly a diagnostic procedure. You don't need it in lesions smaller than 2 centimeters, but the ESGE guideline suggests that if you think it's a cyst, or you can prove it histologically, you can do either surveillance or remove it. So you have to discuss it with the patients. You have to look for shared decision-making. If it's a younger patient, most of the patients will say, if it's a straightforward resection, go for it. Otherwise, I don't want to be on surveillance for the rest of my life. So it's a can indication for the stomach. For the duodenum, for the duodenal nets, we done a study. A coworker of mine, Dr. Vanhoff, he did a multicentric international trial looking at FTRD resection of neuroendocrine tumors in the duodenum. It was a European, US, Indian trial, and we included 170 cases. The net characteristics, they were rather small, and most of them were in the first part of the duodenum, in the bulbous duodeni, and from there was a 35% in the proximal part close to the pylorus. And there are R0 resection rate in the multivariate analysis showed that this to be an important factor. If it's close to the pylorus, the R0 resection rate drops. As also there's a issue with training and with experience. So if you're more experienced, you have a higher R0 resection rate. Looking at the results here, the R0 resection rate in the first part of the duodenal bulb was 56.9%, and from the distal bulb to the trides, it was 82.7%. So location matters for FTRD resection in the duodenum. Coming to the adverse events, there's a big difference between the lower and upper GI tract. You see nearly no bleedings in the lower GI tract, but you see up to 17% bleedings in the upper GI tract. You have to be very meticulous at the resection site. You need to coagulate small vessels at the wall duplications. You have to be there very careful. So that's the difference. 17% bleeding either intraprocedural or post-procedural, 12%. Severe adverse were only 1 bleeding and 2 needed surgery. There's also an ongoing trial that's nearly completely recruited, looking at maybe a first-line indication for the FTRD system with duodenal adenomas. I think the final 2 patients will be recruited this year. So let's conclude. For the non-exposure EFTR in the GI tract with the FTRD system, I think nowadays it's reality, it's Main Street. And I think it's a major step forward in interventional endoscopy. And this non-exposure EFTR, it's effective and safe. It's the Western way. In Southeast Asia, there's much more opening the GI wall, resecting subepithelial lesions, and then stitching it up again. I think the FTRD system is the safer procedure. The resections can be done in the complete GI tract except the esophagus, and the killer indications are non-lifting neoplasias and subepithelial tumors. However, you have to have expertise and you have to have a close cooperation with your surgeons, and the limitation is size. maybe up to 4 centimeters in very, very, very favorable lesions, but realistically up to 3 centimeters, and location plays a role. Thank you very much for your attention.
Well, thanks to Professor Caca for that insightful presentation on the state-of-the-art developments. Just a quick reminder for the audience, you can use the chat function, the Q&A function, to enter any questions that you have, and then we can share that with the speakers later on. Now let's move to another part of the world. I'm very excited to introduce our next speaker, who played a pivotal role in establishing this groundbreaking technique in the United States. Interesting fact is that he actually attended our first FTRD training course in the Americas, which however took place in Guatemala City back in 2017. Please join me in welcoming Dr. Gregory Haber from New York, whose contributions have been instrumental in our success on the American continent.
Yes, thank you very much, Bettina. And thank you to the entire Ovesco team for making all of this possible. Well, it was very exciting to be involved with endoscopic full thickness in North America, and also initiating the whole procedure for the Western audience over here. And it was very exciting to go down to Guatemala for that first training session with Mark, with Jeff Yates, with David Garcia and Julie, all our North American counterparts on the Ovesco team. So let me start by saying the OTSC cap was actually one of the first devices that was available for the concept of a full thickness resection. And this was published as the so-called Dortmund method. So the cap was used to trap the tissue, and then an Inui cap, which was an Olympus device with an integrated snare in the tip of the cap, was placed over the trapped tissue, captured by the OTSC device, and removed in that way. So that was kind of an awkward precursor to the development of the now well-known full thickness resection device. And I have to say that this illustration is now iconic. I think of the 200 or so publications or whatever it is, you will see this illustration in about 100 of those publications. But it's hats off to the illustrators at Ovesco who did such a good job in showing us how it works. And if we look here at one of our early experiences, this was the typical indication, which was a at-risk lesion, risk for cancer with non-granular 2A plus 2C findings. And these small lesions were perfect for the OTSC device for an en-bloc resection. It was less than 2 centimeters, and with the markings to allow us to see it. And you have to remember that your illumination is less with the device, so we always go on to a higher illumination when we go in, and we try to clean out the colon beforehand so nothing is obscured by stool. In this case, with this small lesion, we're able to, of course, pull it into the cap with the grasping device, making sure that the grasping device is not trapped by the clip. And following removal, we have, of course, the tattoo. We see the flip side with the serosa. So this was a very exciting moment for us to realize that we could actually cure cancer, and that, in fact, was a T1A superficial cancer. So this was the beginning of our experience with FTR. And then the other application, which was very exciting, was to use this with previously unresectable appendiceal orifice lesions. And we have currently a publication in Press, which is a review of our patients with appendiceal orifice resection. And we can see that we were able to remove en bloc 30 of the 35 cases, and 5 with a hybrid technique. It's interesting that our results mirror that of the larger multi-center trials and registries. So we had 4 patients out of the 35, 14% with appendicitis, 2 of whom had it acutely, and two of whom required surgery. The other two managed conservatively. One bit of advice for our audience is that we put all of these patients on antibiotics for 1 week following appendiceal resection as a protection against appendicitis. Not mentioned in this immediate results, we did have one delayed appendicitis, which occurred about 5 months later, and we're not sure to what extent it was related. But one of the major things we were worried about was the residual appendiceal stump after the clip was placed. So one of the principles of following up on these patients was to ensure no delayed complications, especially concern about a mucocele. And you can see here that we were able to get a sort of medium length follow-up in about half of our cases, and happy to report there was no evidence of any mucocele. What we did find, though, was 2 fistulae into the terminal ileum. And in both of these cases, this was removal of a lesion over the appendiceal stump, or the residual appendiceal orifice. And what had happened was, from the prior appendectomy, there was adherence of the ileum to the scar tissue on the serosal side, so that when we removed this lesion, we had these benign fistulae into the terminal ileum. There was no symptomatic consequence of this, and no really adverse events subsequently following these patients. You've heard a lot about the hybrid technique. Karel was very kind in reviewing their experience. We also were very excited about using this combined with EMR for the periphery of large lesions and reserving FTR for the central adherent non-lifting section. And we published our experience back in 2021. And you can see that with the hybrid approach compared to the on-block approach, we had a similar RO resection rate, close to 90% in these cases. So that, we consider this as an adjunctive treatment for those problematic cases. We then got more interested in the curative ability of FTR for polyps with cancer. So we looked at endoscopic full-thickness resection for what we considered high-risk lesions, those which had topographic features suggestive of cancer, or high-grade dysplasia or cancer on prior biopsy. And we can see here that we did have 38 cases in total. We had 35 patients that we were attempting the FTRD. In 2 of these cases, we were unable to pass a very strictured sigmoid. So in contradistinction to what Karel showed you, we have had some patients with diverticular disease, strictured areas that where passage was not possible. I can talk a little bit about the PROVE device in the question and answer. But you can see we had technical success in 33 cases. I think for the purpose of time, I won't go through the whole outcomes with these different groups. But what I will say is that we had RO resection in 95% plus. But in spite of RO resection, these were the 8 cases out of the 35 who had surgical indication. And the surgical indication was mainly lymphovascular invasion, which was present in 7 out of the 8. One case had metastatic disease. It was a case that never should have had an FTR. And one of our colleagues in our group with less experience was a little bit too enthusiastic. But what surprised me that in spite of lymphovascular invasion, in 7 of the cases, on resection, there was no residual cancer and no lymph node involvement. So I'd be interested in hearing Barbara's comments on that. All of them had, the other prognostic indicators were good. They were well or moderately differentiated with a low budding score and negative perineural invasion. So this will warrants further discussion as to who we send to surgery. Another bit of information, which I don't think I've seen in other publications, was the depth of resection with the full thickness device. And so when we looked at our 35 patients, and we've noticed this, of course, clinically, our ability to get what we would call full thickness resection was in 10 of the 35. 8 of them we got muscularis propria, but there were 12 patients where we only achieved submucosal resection, and in a minority of 3, just a muscularis mucosa. Now, having said all of that, in all of these 35 cases, the vertical resection margin was clear. So, you don't necessarily have to have serosa or subserosal fat to get your RO resection. I think what is very important to us is to look at this as an alternative to possibly ESD, which is a much more complex procedure, requires much more time, much more skill and experience. So you have to realize that the actual size of the cancer in polyps with cancer is very small. And the median size of cancer in our 35 patients was 7 millimeters, within a median lesion size of 30 millimeters. And of the lesions containing cancer, 17 of the 18 had an RO resection. So I think we have to look at this as a clearly viable alternative to ESD for high-risk lesions in the colon. Remember that T1 cancer in a polyp, it rarely exceeds 2 centimeters. ESD is much more difficult, of course, if you have fibrotic lesions with incompletely resected malignant polyps, which is frequently the type of patients that are referred to a tertiary referral center. So I know I'm sort of at the end of my time, so I don't want to spend too much more time, but I do want to take a moment to thank Ovesco. The team has been tremendously supportive. I think the company and the principles of the company are admirable. They're very careful, very thoughtful, ensuring that whatever they develop as a device is safe. And we can see that the amazing sort of absence of mortality in this huge number of cases is remarkable. Thanks to, of course, the American team, Jeff Yates, who's been absolutely wonderful and a leader in the Americas for Ovesco and the full thickness device. Of course, Julie Easter, David Garcia, who's here beside me. And finally, thank you, Bettina, for putting all this together. I'll be happy to address questions as they come along.
Thank you, Dr. Haber, for sharing your experiences from the United States, and also I appreciate it. The thanks goes all back to you. Now, let's shift our focus to a different part of the world. Our next speaker hails from India, where the market dynamics and clinical settings present unique challenges and also opportunities. He has garnered extensive experience and made significant strides in implementing FTRD in India. So please join me in welcoming Dr. Zahir Nabi from Hyderabad to share his experiences and perspectives from India.
Hello, everybody. I'm Dr. Zahir Nabi, consultant gastroenterologist and director interventional endoscopy at Asian Institute of Gastroenterology, Hyderabad, India. And webinar, and which is held on the occasion of a decade of Ovesco. And I'll be speaking about establishing endoscopic full thickness resection in India and what is the current situation and difficulties. I don't have any disclosures. So in the next few slides, I'll be talking about the current situation of endoscopic full thickness resection in India, what are the challenges and way forwards. So if you see the concept of device assisted FTR in India, it's not very old, but currently it was not very popular for colonic lesions. The main reason being One, that we don't have a big insurance system here, so we are picking up on that aspect. So people are paying from their pockets for all the procedures. So is one reason that any device assisted procedures, they are not an instant hit in our country. The second is the incidence of colon cancer. It's really low in this part of the country, and if we see, it is among the lowest across the globe. So that's the main reason that in for colonic lesions, endoscopic mucosal dissection, endoscopic submucosal dissection or surgery, these are the options which are more often utilized as compared to endoscopic full thickness section, which is used for a selected minority, like those with scar recurrences or at special places like periappendicular or peridiabetic lesions. And also on occasions, we use it for taking full thickness biopsies, for example, in Hirschsprung's disease, to evaluate those particular cases. So in Indian scenario, the device-assisted full thickness resection, or the FTRD, is mainly lesions that is localized to stomach or duodenum. The main reason being that the number of endoscopies being performed has increased significantly in the Indian scenario, and a lot of neuroendocrine tumors are being diagnosed incidentally. Similarly, we now diagnose a lot of gastric submucosal lesions, which are, of course, incidental. And we know that with conventional techniques may be risky, especially for lesions which are arising from fourth layer or muscular layer, and lesions localized in first or second part of duodenum because of high risk of perforation. So at AIG, we started our journey with EFTR long back, but we were doing exposed endoscopic full thickness resection. Means we used to utilize a knife, and we can call it freehand EFTR or tunneling EFTR, means not with the assistance of any particular device. Or we used to do hybrid EFTR, but the problem with the exposed or the conventional EFTR, that is without assistance of a device, was the time taken for the procedure and the complications associated with it. So you can see that this is a neuroendocrine tumor that we removed using the conventional endoscopic full thickness resection technique with the help of a typical ESD knife. And you can see a big perforation here that we had to close with the help of loop and endoscopic clips. So although there are these technique we still utilize, but we realize now that closure can sometimes be really tricky in these situations. Therefore, we have started favoring endoscopic full thickness resection using the assistance of device. So these were the various issues that we faced. Initially, we didn't have expertise. Closure required a lot of time and specialized techniques, and procedure time was huge while we were doing conventional EFTR or exposed EFTRs. So that is for last few years now. The device-assisted EFTR or non-exposed EFTR has virtually replaced the conventional EFTR that we used to practice a few years back. And the challenges and hurdles while when we started device-assisted EFTR in our setup were many. Initial challenges were case selection. There were not many studies on the use of dedicated gastroduodenal FTRD device. So there was a lot of cases that we selected, especially in gastric cyst and a couple of duodenal cysts that we encountered, and we couldn't remove them. So patient selection was a bit shaky in the initial part of our FTRD program. And then we realized that probably gastrointestinal tumors, especially those located in stomach, they are not the best of the lesions to be removed using device because the rate of our R0 resection is low, and this study was published from Professor Arthur Schmidt's group, and the R0 resection rate was really low. Coming to other lesions, then we gradually realized that there are some good lesions and there are some not so good lesions to remove with gastroduodenal FTRD. So this was the time when we were gaining our experience with this device. So, for example, lesions which are close to pylorus and attached to the pyloric ring, probably they are also the lesions which cannot be completely brought into the cap and resected and blocked. So this is a case that we did in the initial part of our FTRD days, and you could see the remnant tumor here because this lesion was very close to the pylorus. There are other lesions that we could not achieve technical success, and there were the cases where there was some scarring in duodenum, and probably these could have been the cases where we could have avoided FT using a FTRD device. So the ideal lesion that we realized was located along the anterior wall that could come and pass to the device and could be easily brought in. It's mainly endophytic, means growing inside the lumen. It's globular, not flat, and with minimal scarring. So these are some of the ideal lesions that we have. We have pasted these pictures in our endoscopy suite, that what are the lesions that we are going to look for while we are using a device assisted EFTR. The second problem that we faced in the initial part of our EFTR days was coordination with the assistant. So the snaring and the clipping, that coordination, we all know that that's very important, and some of the on some occasions the assistant failed to close the snare while we deployed the clip. So that is another thing that we faced in on the initial few occasions. Then some adverse events that we encountered, and some of them were like incomplete resections, some of them were delayed bleeding, and some of them were partial obstruction of the lumen, especially in second or third part of the duodenum because of using some suction. So we strongly recommend against suction, especially in second part of duodenum. Now we realize that it's a very vascular, especially duodenum, and we have to be very careful and recheck after a few hours if there's any delayed bleed. So this is our protocol, that we always check them for any delayed bleed and hospitalize them for at least 24 hours. So AIG experience, this is our initial study published where we compared exposed versus non-exposed endoscopic full thickness resections. And in this study, we found that although the outcomes were similar, but the time taken for the procedure and adverse events were significantly less with the device-assisted EFTR, that is gastroduodenal FTRD. So this is our protocol that we follow at AIG, that how to remove gastroduodenal SM lesions. We seldom use it for colonic lesions, but we use it quite frequently for gastroduodenal subepithelial lesions. And we follow this protocol to optimize our success based on our experience with technical failures and adverse events. The Indian experience, if you see that now we have a multi-center experience. This is a study that we have recently conducted, and the study involves 138 patients from 10 centers in India. Most of the lesions were located in stomach and duodenum, 80% of the lesions were in first part of the duodenum. The median size of the lesions was 12 millimeters, and we could reach the lesion on most of the occasions. Preemptive dilatation was done on almost half of the occasions, especially upper esophageal fracture. Interestingly, the most common technique for lesion pull was using both grasper and suction. The procedure time, you can see that it's only 20 minutes, and most of the cases were done under propofol sedation, and general anesthesia was usually not required. There were no major adverse events except one, where this case had severe bleeding post resection, and this case required angioplasty. There were a couple of cases of perforation, but they could be managed endoscopically. Now, coming to the outcomes, majority of the lesions for neuroendocrine tumors, R0 resection could be achieved in 87% of cases, and recurrence was observed in only 4 cases. To summarize, we have now a very good armamentarium for endoscopic full thickness dissection, that is this gastroduodenal FTRD device. And we choose our lesions based on the location, the size, and whether the lesion is predominantly intraluminal versus extraluminal. There are few challenges here, and we need to address that. We need to realize that what are the cases that are optimal and suitable for this device assisted. Of course, there is need for continuous improvement, not only in the physician who is performing the procedure, but also in the device, if there can be a scope of improvement for the technical ease, some of the snare closure issues, and clip deployment issues. The future of focus studies, should be that how to choose an ideal lesion, role in gastric submucosal lesions, predictors of success, technical as well as clinical and long-term outcomes, and the scope for refinement of device. This is one of the studies that we are doing. We are comparing a device-assisted EFTR versus ESD for duodenal neuroendocrine tumors. Currently, we are recruiting patients and hope to complete the study soon. Thank you.
Well, thank you, Dr. Zahir, for sharing your experiences and also the Indian data. Now, let's open the floor for our first Q&A session and see what questions our audience had for our speakers. So please welcome back, everybody. You can now turn on your cameras and your microphones, and then we will discuss. So we've had a few questions from the audience, and maybe we'll start with the duodenal questions, and maybe that's something that Dr. Zahir or Professor Caca could answer. What the difference is, why do we see such a significant delta in the R0 resection rates for nets in the duodenal bulb versus the rest of the duodenum? So what are the challenges?
I think it's quite obvious. I think it's the anatomical location. I think as Dr. Nabi has shown, if it's right behind the pylorus, you cannot get the kinking with the device, and so you sometimes end up with a lower R0 resection rate. Is that correct, Dr. Nabi?
Yeah. I completely agree with you. So the first part of duodenum is, in my opinion, is more fixed. It's difficult sometimes to bring the lesion inside the cap. And so that's why it's very important to carefully choose the lesion. So flatter lesions with a flat morphology, I think they are the lesions which sometimes it's difficult to bring, even though they are at an optimal location, but sometimes it's difficult. On the other hand, if you see second part of the duodenum, the mucosa is much lax, and the moment you catch it, it's ready to come inside the cap, and it's quite easy to resect them. So that's the reason I feel first part of the duodenum, I think you need to be very careful while selecting the cases. I did show some pictures. I think that may guide in choosing appropriate cases. And of course, with experience, you can achieve the level of proficiency that Professor Caca is having. But it's all a matter of like practicing and performing those cases frequently so that you can know the tips and tricks of how to optimally bring the lesion inside the cap and doing an R0 resection.
I just want to add a couple of things about the duodenal cap. I think that what you have to be careful about is that the tip of the cap will go through the pyloric sphincter, but the ring, which drives the cap drives the clip off the cap, that ring is wider than the tip of the cap. So what happens, and I saw this in your picture too, you think that you have your cap entirely in the duodenum. You just have the front end of the cap in, and your ring is outside the pyloric sphincter. So the trick to overcome that is you advance the entire cap and ring beyond the lesion towards the junction of D1 and D2. And then when you pull back, the white ring will often stay within the duodenum without popping back out onto the pyloric side. So you have to really understand the difference in the diameter. And the second thing I would point out is you have to be careful. We've had one case where when you cannot get inside, but it's right sort of very close, and you try to pull the lesion through the pylorus onto the gastric side for resection. You've got to be careful you don't suck in mucosa, soft, in the pyloric ring, if you like, and get a complete obstruction. Happened to us once, but fortunately we were able to overcome within a couple of days. So those are a couple of tips as to how to manage lesions that are close to the pyloric sphincter.
I think that's a very important point raised by Professor Greg Haber. So whenever you see a duodenal lesion, I think it's important that you cross the duodenum and go into the second part of duodenum, bring your device back so that you know that your entire device along with that ring has really entered into the duodenum, because pylorus can be really challenging. It can block your ring, and although your with the physical force, your cap may appear to be in front of the lesion, but actually the ring is outside the pyloric ring. Is that exactly the point you tried to mention?
Yeah, exactly. I think that's very important, and I think it's it's good to advise our audience about it. Yeah.
Well,
I think sorry.
yes, please.
What we also should mention is that with the subepithelial lesions, sometimes it's difficult to get the lesion with forceps inside of the cap. So a lot of time it's helpful to use the anchoring device to go right into the submucosa and right into the lesion to pull it into the cap.
It's interesting you say that, Karel. I never use the anchoring device. And that's probably, but my RO resection rate is probably not as good as yours, so maybe I should start. But I'm always a little bit worried about the anchoring device in the duodenum with all that vascularity. I mean, but you've obviously had good experience with it.
And never encountered a problem. If you encounter bleeding, I think Dr. Nabi showed it wonderfully that you have to be very, very careful in the duodenum, because you have up to 20-25% bleedings from the vessels at the resection site. So you have to meticulously coagulate them, as he's shown very nicely.
Yeah, and probably it goes without saying you have to be extremely careful to stay away from the major and the minor papilla. So you must look with a duodenoscope. If you don't identify it, you have to clearly identify it, because you will, I would say, when you begin, you think you're getting less tissue than you actually are. So even if you think you're a good distance from the papilla, you probably should say to yourself, I better go a little, if it's not, I should be a little further away. I think you should err on the side of staying far away from the major and the minor papilla.
Yeah, I think that's a very important aspect to mention as well. I would maybe pose another question regarding the lower GI, appendiceal orifice. We've had some questions here. So, Dr. Haber, there was a question regarding your routine with regards to administering antibiotics when you have an appendiceal lesion. Could you repeat that?
Right.
Maybe?
I mean, we give everybody prophylactic antibiotic at the time of the procedure, but for the appendix in particular, we maintain antibiotics for 1 week. I don't have any objective evidence to say it prevents the appendicitis or not, but we do it routinely, just empirically.
Yeah. I totally agree with that. So for appendiceal lesions, it just exactly as you say, we don't have any proof it prevents the secondary appendicitis, but at least it gives a better feeling. Although I must add that for all other indications in the colon, we stopped giving any antibiotics already quite early. So I think now for at least the last 7 years, no antibiotics during any procedure in the colon outside the appendix. And yeah, without any consequences. So
That's
Yeah.
interesting. I think you can see differences between the different
Yeah.
countries and their approaches. Now, there is maybe a more general question to all of you. How do you approach patients with where you perform FTRD at the penicillin orifice? Do you make a routine CT scan, given that the patient is still asymptomatic, or how is your follow-up procedure?
So we don't do a CAT scan before, and the results, you have to discuss it with the patient. I mean, it's also very interesting from Dr. Haber's results. I mean, it's 11%. In our group, it was 14%, so it's about the same ballpark. So you have to discuss it with the patient. So you have a risk of 10 to 15% of encountering an appendicitis. In 50%, we can treat it with antibiotics. In the other cases, you will have to go to surgery. So I always ask them, do you like to be cut open in the first place, or maybe take a risk being cut open in the second place? So most of them say, I take the option number one.
Yeah, I have to say that one of my great concerns initially was if we're leaving a remnant of the appendix because of the FTRD, would that patient a few years later present with a mucocele? Because if you've occluded the lumen and it happens to, heal in with an occluded appendiceal stump, if you like, I was concerned about that. That's one of the reasons that I decided to do sort of a delayed CT. We called all of our patients, and we were able to convince, they were all asymptomatic, but convinced half of them to have a CT scan about a year and a half later. And, quite sort of reassuringly, I should say, we didn't find anybody with a mucocele.
No. That's nice. We had the same experience, indeed, Professor Haber. And I don't think I have a video in my presentation, but we also have seen that it's so nicely after, the clip is off usually around 4 months later. And there's a nice recanalization. It just looks like the normal appendix. It's shortened on ultrasound, but you always wonder what happens to that appendiceal remnant. Well, it just stays there. It stays vital. It recanalizes. And that's nice.
It's a frequently asked question, though. What happens with the remaining appendix? So there's still a little bit mystery about it. We do still have a lot of questions, which I would postpone to the second Q&A, and I would continue with the next session. So thanks to the audience for your questions and your active participation. Now let's transition to the more hands-on aspects of FTRD with EFTR with FTRD, and also back to the American continent. I am pleased to reintroduce Dr. G, who has been instrumental in our training efforts in the United States, and he will share valuable experiences, some tips and tricks, and also troubleshooting strategies for using FTRD in clinical routine.
Thank you very much for the kind invitation to give this talk. My name is Philip G. I'm at the University of Texas MD Anderson Cancer Center in Houston, Texas, and I'll be talking to you about our U.S. Cancer Center FTRD experience, which I like to call small, deep, and tough. So celebrating the history of endoscopic resection, we wish a happy birthday to the FTRD. Endoscopic resection goes back to the 1960s with snare polypectomy. EMR came in the 1970s, and then cap and band assisted EMR in the 90s. ESD came in the 2000s, and again, a very happy birthday to the Ovesco FTRD. This is the original paper of an animal study that came out in 2011. So where I work at MD Anderson Cancer Center, this is a well-known, high-volume, well-established endoscopic resection practice. This dates back to my senior colleague, Dr. Raju, who built an EMR program in 2009. I was recruited to MD Anderson in 2018 to build an ESD program. And then in 2020, my partner, Emmanuel Coronel, and I, the two of us, started an FTRD program from August of 2020 to now. We primarily use FTRD for 3 major indications at my institution. The first major category are for primary or salvage resection of impossible polyps that are not amenable to EMR or ESD. So this is a fantastic salvage technique. The second is resection of malignant scars. This is something where our surgeons have really been pushing the envelope in sending us referrals for patients who have, for example, had incomplete or piecemeal resections of malignant polyps, which you can actually see in this video to your right, as well as incomplete or piecemeal resection of neuroendocrine tumors. The third category of FTRD has been for primary resection of subepithelial lesions. Again, primary resection of neuroendocrine tumors or primary resection of small GISTs up to about 12 to 14 millimeters in size. As of the time of this presentation, we are at 191 cases over the last 4 years, which makes us one of the highest volumes in the country, or if not in North America. And this includes 38 gastric cases, 23 duodenal cases, and 130 colorectal cases, of which we have achieved 93% technical success. 8 cases were aborted for a complete resection rate of 74%. The mean procedure time, in which defined as the time for the device going in to the device coming out, has been about 11 minutes. We've had 15 adverse events, or 7.8% adverse event rate, which included 2 delayed perforations in the colon, 4 delayed bleed, which included 3 in the rectum and 1 in the stomach, as well as a small potpourri of other adverse events related to the FTRD system. 6 hospitalizations, which included for 2 perforations, 1 bleed, some pain symptoms, a delayed recovery, and an unusual case of pyloric obstruction. One of the things, as I mentioned, that our surgeons, surgical colleagues here have really been pushing the boundaries for us here, have been encouraging us to endoscopically resect patients who have had incomplete resections for malignant polyps or neuroendocrine tumors. And the logic here is that FTRD, or full thickness resection in general, allows for formal T-staging in selected circumstances when somebody has an incomplete or piecemeal resection of malignant colorectal polyps or of neuroendocrine tumors. You can see here in this top strip, boxes A through D shows the resection of a residual malignant polyp. Boxes E through H on the bottom shows resection of a residual neuroendocrine tumor. This was from DDW a year ago. At that time, we only had 48 cases. Now we have a lot more. But you can see even then, out of 48 cases, let's just round up and say 50, 5 out of those cases, so about 10%, had residual adenocarcinoma, and another 10% had residual neuroendocrine tumor. So that means that out of the cases that we do, there's about a 20% hit rate. So about 20% of cases will have some sort of residual neoplasia, which means that the other 80% will have no residual tumor and therefore establishes a T1 stage for the surgeon. Of course, it is important to know that this has to be done with multidisciplinary approval. All of these cases are done as referrals from our surgical colleagues, because surgery is the standard of care for malignant polyps, whereas local resection is not. So full thickness resection ends up being appropriate, especially in patients who are poor surgical candidates, or in patients where the benefits greatly outweigh the risks in terms of the location, for example, in the rectum. And it's important to know that for these patients where we end up playing the role of the surgical oncologists, we will end up being the ones who follow these patients over the long term with both endoscopic as well as oncologic surveillance. The other major category for full thickness resection in our practice has been neuroendocrine tumors, and this has also been a bit of a pleasant surprise. But it makes sense. Neuroendocrine tumors are predominantly subepithelial. They originate in the bottom of the mucosa in the lamina propria, and so it easily grows downwards into the submucosa. And therefore, these lesions end up being very poorly suited for EMR or ESD, because you end up getting positive vertical margins. And so it ends up being very well suited for an EFTR-based approach. So this was from DDW last year as well. At that time, we had 56 GI tract neuroendocrine tumors. Now we, of course, have a lot more than that as well. And this included a pretty even spread of gastric, duodenal, and colorectal neuroendocrine tumors. The important thing here is that we found that amongst patients where we did a full thickness resection, the histopathology outright changed in over a quarter of these cases. 8.9% of these lesions were noted to have increase in grade based off of what was originally believed. So in other words, they were referred with a grade 1 net, and they were found to have a grade 2. And 17.9% had upstaging. So in other words, they were believed to have a T1 net, only to be found to have a T2 or T3. We found a new findings of lymphovascular invasion in 17%, as well as perineural invasion in 7%. In other words, high-risk histopathologic features that were not known prior to FTRD. 3 of these patients went to surgery, in fact, because of these findings, and 2 of them were actually even found to have lymph node metastasis at the time of surgery. And FTRD can be combined with other modalities as well. So, for example, take the example of this 50-year-old morbidly obese male who we were referred for a quote-unquote 2-centimeter neuroendocrine tumor at the rectosigmoid junction, clinically believed to be T1 versus T2. You can see the EUS photos here. And so this obviously seems a little bit big for FTRD. So what I did was I did ESD first to release the edges, and then I did a FTRD of the central neuroendocrine tumor. We achieved a complete resection here, as you can see from the photo. And the final pathology came back as T3 with lymphovascular and perineural invasion. There was residual neuroendocrine tumor that was found on the subserosal surface during surgery, and 2 out of 33 positive lymph nodes. Final staging here is T3N1. So again, having a full thickness resection was the critical piece of information that pushed this patient towards having a very necessary surgery for their disease. In the second half of my talk, I'll talk about some lessons that I learned along the way. Having done this many full thickness resections, definitely have gotten to know the device very well, including all of its quirks and nuances. The first thing is the timeout. So I learned this lesson very early on that you need to be well prepared with this device, which is not very forgiving if you're not prepared for it. And so what I decided to do was at our institution, we instituted a mini timeout process right before the lesion is grasped and right before we're committed to the procedure. We check the equipment, make sure the patient's grounded, the surgical unit settings are appropriate, the active cord is plugged in, the foot pedal's in the right place. Everybody knows what they're supposed to do. One person holds the snare, another holds the grasper. In challenging cases, we even have a third assistant, which includes either advanced fellow or second physician. There's a couple of other interesting things and that we've encountered. One is sometimes we're unable to reach the lesion, as in this case where we're struggling in the sigmoid colon. For these types of lesions, for these types of situations, we have aborted before. And again, this is because the colonic FTRD adds 23 millimeters of a hard, non-bending segment of scope in front of the scope itself. So we try our best. We ensure the cap is well seated, abdominal pressure, change position. There have been a couple of times when I've succeeded by leading with a balloon dilator in front of me to kind of pull myself in. But overall, don't push your luck. We have aborted, I believe, 8 cases because of this. The other major thing that I've learned is just be careful of extraluminal structures. This is a patient who had a gist that was referred in the rectum. So a rectal gist. Let me try this again here. And we just have to be very careful with the anterior wall, especially in female patients. This was a small gist along the anterior wall. And when I first started doing FTRD, one of my colorectal surgeons specifically warned me about this, to always perform an EUS before using the FTRD for the anterior rectum, whether male or female, because in female patients, like in this case, the rectal vaginal septum is directly underneath the gist, and so we're separated from the vagina by only about 2 to 3 millimeters. In men, that could be the prostate that's directly underneath the lesion. We're very careful with the anterior rectum. I have aborted a case before, like in this case, for example, and we perform an EUS before every rectal case just to make sure that we're careful about adjacent structures. Anal trauma is another thing to consider. This is the picture that always makes me kind of sit up in my seat a little bit when I look at it, and especially when I watch this video of rectal entry. It always kind of makes me cringe a little bit when I watch this video. So, it's important to make sure that patients are aware that this may possibly be painful. And so we lubricate every patient with 2% lidocaine jelly to the anus when we do lower FTRD, and I do personally warn every patient about this. So along similar lines, sometimes there can be anal stenosis, and that can present a challenge in terms of introducing the device. Here you can see this patient has an anal stenosis with a pre-existing anal fissure, in fact. And so what I did was I used a gastroduodenal approach where I use a balloon to navigate myself into the colon. So leading with a 20 millimeter balloon, and again, I use an entire stick of 2% lidocaine jelly for these types of cases. Sometimes you can get edema after resection, like in this case where we did a FTRD in the sigmoid colon, and then afterwards, even though everything went well, you kind of wonder to yourself, where's the lumen? So make every attempt to identify the lumen after FTRD. We switch to a smaller scope, and if you really cannot find the lumen, just consider observing the patient and very slowly advancing their diet while they're in the hospital. Last but not least, sometimes you just cannot grab the lesion. Here we have a malignant polyp where we're trying to remove, and you can see it's starting to tear a little bit, and that's not good for histopathology. So here we've switched to a Ovesco 3-pronged anchor, and we're able to lift the lesion into the cap. So for me, I always try to grab the base or the bottom edge of the lesion. I pull slowly and consistently. These are the types of cases where it can be very helpful to have a second endoscopist either hold the scope or deploy the clip. And we can use a variety of different devices as an alternative to the grasper. Sometimes we'll use the anchor device, as you can see here. Sometimes we'll use the Apollo tissue helix. Especially for double channel scopes, you can use 2 Apollo tissue helices to pull traction. But suction is your last resort, again, because of the possibility of adjacent organs. In summary, putting it all together, I like to share this story of an impossible resection of a 60-year-old morbidly obese male who had a BMI of 55, so well over 250 kilogram patient, not a surgical candidate, and found to have this humongous obstructive polyp in the rectosigmoid junction. I tried an ESD because that was the original referral. It was impossible, and I sent the patient back to surgery. I said, this is not possible. And they said, well, we can't do it either. So if you can't do it, we can't do it. We're gonna have to wait for the patient to either lose weight or develop cancer. And even then you might not be able to do much. So I said, well, that doesn't sound right. It doesn't feel right. So what I did was I eventually did a piecemeal EMR at the top, ESD of the base, full thickness of the core, got a complete resection, no cancer on pathology, clean scar with no recurrence 2 years later. So my general approach, for polyps, I still usually use cold stare, EMR for intermediate size, ESD for large polyps. I tend to default to EMR in patients that are very sick where we don't have much time. But FTRD plays a very prominent role for difficult or fibrotic polyps. Those are excellent cases for FTRD. For resection of malignant scars like the leftover malignant polyps, leftover neuroendocrine tumors, and also for subepithelial lesions like neuroendocrine tumors and small cysts are excellent candidates for FTRD. But really, in conclusion here is that we have a mature endoscopic resection toolkit in 2024. The major thing here is that surgery should no longer be indicated for benign lesions in general. And as you can see from the examples that I've shared, sometimes the patient is just simply not a candidate for surgery. But realize that EMR, ESD, and full thickness resection are actually very complementary parts of the same endoscopic resection toolkit. They all have their strengths and weaknesses. I do not like doing open FTR. I think that's not really standard of care, and that's why if I were to ask to do full thickness resection, I prefer a safer FTRD based approach. FTRD, I very firmly believe, is an underrated, highly useful component of this resection toolkit. It's used for all sorts of purposes like salvaging impossible cases, resecting malignant scars, of course, with a mandatory multidisciplinary discussion, and resecting subepithelial lesions. Thank you very much, everybody, for your time.
Well, thank you, Dr. G, for that very informative hands-on session and also a troubleshooting guidance. Now, we are honored to leading over to our next presenter, the last one in the round, and I'm happy to also have a female speaker in our webinar. Her work and dedication have been crucial in advancing scientific research and transforming clinical routines in terms of a very particular indication for EFTR. She will be presenting compelling data that highlights how FTRD has been and will continue to be a game changer in the field. Please join me in welcoming Dr. Barbara Bastiansen.
Good evening, everyone. So it's a privilege to be at this special anniversary of FTRD, and I'm very happy to share some of our latest results of EFTR for T1 colorectal cancer, as I really believe that it has been a game changer for the treatment of T1 colorectal cancer. So as you all know, T1 colorectal cancer is quite a relevant disease, but because we encounter it quite frequently now that we have bowel cancer screening programs, and as the overall risk of lymph node metastasis is quite low, there's a significant chance for a local resection and cure if we have techniques to remove those cancers radically and in a safe way. So this is what guidelines tell us. If we encounter a lesion suspicious for T1 colorectal cancers, then we try to make an optical assessment on invasion depth. And when we see the lesion might be superficial invasive, guidelines direct us to unblock EMR, EFTR. But when there are signs of deeper submucosal invasion, guidelines direct us to surgery. So a lot of weight has been put into our optical assessment of invasion depth. And the question is whether that is a good guidance, because how accurate is our estimation of invasion depth? And to be honest, it seems to be quite disappointing, even in experts' hands, as shown by this quite recent paper involving both European endoscopists as Japanese endoscopists. And as you can see, the accuracy rates of optical diagnosis is quite low. So there is a significant chance of both underestimation as overestimation using optical diagnosis only. Then, do we really need a transmural resection for T1 colorectal cancer? Well, first of all, we know that 60% of all T1 cancers are sized 2 centimeters or less. So that's the perfect size for EFTR. We also know that the majority of T1 cancers have deep submucosal invasion at diagnosis, even if the invasion depth was expected to be more superficial. We also know that from ESD data that the R0 resection rates for the deep resection plane, so the vertical margin, really drops to very low numbers in SM2, SM3 lesions, so even 35%, and that's not good enough for cancer, of course. So we now know that deep submucosal invasion is not an independent risk factor for lymph node metastasis. This meta-analysis could be performed based on individual patient data from both European as Asian centers, showing for the first time it's not an independent risk factor, deep invasion. And when there's only deep submucosal invasion and no other histological risk factors like lymphovascular invasion or tumor budding, then the absolute risk of lymph node metastasis is really low, is only 2.5%. And we also see that in 40% of all deep invasive cancers, no other risk factors were present. So meaning that a significant proportion of all deep invasive lesions can be cured by a local excision only. So that really opens the door for a local excision as first step in treatment of T1 colorectal cancer to allow for very detailed histologic risk stratifications. And this is what EFTR can provide. It provides high quality specimen with indeed exact risk stratification in nearly all cases. So this is where EFTR makes the difference, both as a primary treatment for suspicious lesion as an excisional biopsy, or as a secondary scar excision after previous incomplete resection of low-risk cancers. And because of the sake of time, I will only focus now on the primary treatment. As the Netherlands disregarded depth of invasion as risk factor already years ago, we were quite early adapters of endoscopic full-thickness resection in T1 cancers. And indeed, it's the most frequent indication in our registry is T1 cancers. This was the first publication published in 2022. 132 primary resection were included with a median lesion size of 15 millimeters. And it already showed that the R0 resection rate for lesions smaller than 2 centimeters was 86%. Also interesting to see was that the strict curative resection rate, so including depth of invasion as risk factor, would be 24%. And that's completely equivalent to what we see for curative resection rates in ESD data for cancers. But when we exclude deep invasion, the curative resection rate would go up to 61%. So that's a significant increase, indicating that indeed large proportions of deep invasive cancers do not have any other histological risk criteria. So now we finally have longer term follow-up, which was presented by Sander Albers on ESG Days this year. and I would like to present these data to you. So we included 559 EFTR procedures for a suspicious T1 colorectal cancer, with tumor location in 82% in the colon and 18% in the rectum, with a median lesion size of 16 millimeters and a technical success rate of 90%. Now, if we look at histology, if we look at the 559 procedures, we first of all see that in 4% of cases, EFTR could not be performed, either by not reaching the lesion or when the lesion turned out to be not mobile enough to perform resection. And then if you look at the histology, you immediately see that indeed the majority of cases were deeper submucosal invasive cancers. But you also see the limitations of our optical diagnosis, 18% non-invasive lesions, but also 17% T2 cancers. Now, if we look at R0 resection rates, these were really high. So both for superficial invasive lesions as for deeper submucosal invasive lesions, the R0 resection rates were really high, 88 and 91%, performed in 28 different hospitals, not only high volume ESD centers, but in both teaching as a non-teaching hospitals. So that's really a striking high number of R0 resection. And this is where I believe EFTR makes the difference. Then if we now focus on the T1 colorectal cancers only, so those were 346 cases, half of them were assessed as low risk, including nearly 70% deeper invasive lesions. Especially in the early days, some of them still underwent completion surgery despite no other additional risk factors, but none of them had residual cancer in the surgical specimen. Indeed, again, confirming that we should really reconsider invasion depth as indicator for surgery. And then in the high-risk cases, we see that only 52% of patients underwent completion surgery despite high-risk features. So the other half did not undergo surgery for comorbidity reasons or patient preference reasons. And in this selected very high-risk group, we see that the residual cancer in surgical specimen was 16%, so mainly lymph node metastasis. Now, if we look at the follow-up of those patients, and we included 272 patients with at least longer-term follow-up. If we look at the low-risk surveillance group, so that's including 2/3 of deep invasive lesions, we see one patient had a cancer recurrence that could not be treated with salvage surgery. Unfortunately, this is the tumor biology that we know, that even low-risk cases do not have a 0% chance of distant metastasis. So we had one case here. For the high-risk surveillance group, cancer recurred in 3 cases, so that was 5%, despite histological risk factors, and 2 out of 3 could still be treated with a surgery with curative intent. Then if we look at the patient that did undergo completion surgery, we see that also completion surgery, of course, does not completely prevent cancer recurrence. So 4 cancers recurred, 6% of cases, and these were all, of course, distant metastases, not amenable to salvage surgery. Yeah, so in conclusion, I hope that the data I have shown convinces you that EFTR indeed is a very highly effective primary resection tool for T1 colorectal cancer. It delivers optimal histology and complete risk assessment, and overall very high R0 resection rates, even for deeper invasive lesions, with a very low risk of cancer recurrence at longer-term follow-up. So it really expands our endoscopic armamentarium for T1 cancers, and it allows for organ preservation in a large proportion of patients. So for future directions, I believe that would be interesting to further explore hybrid EMR, EFTR for larger lesions with a small unifocal area of cancer. For the time reasons, I don't think I can show you the full video, but I hope we can have some discussion about this this potential new technique during the discussion. I would like to conclude by saying happy anniversary, Ovesco, and also I would like to use the opportunity to say a special thanks to Johan Kuppens, who's not working for Ovesco anymore, but is now doing other important stuff, as you can see. And Johan trained me in EFTR 10 years ago and helped many Dutch centers through their first cases. So highly appreciated, Johan. And further, of course, I would like to say a big thank you to all collaborating Dutch EFTR centers. I look really much forward to our further discussion.
Well, thank you very much, Barbara, for your fantastic presentation and your great data that you've been showing, and for your invaluable contribution to advancing this field. As we are approaching the conclusion of our webinar, we now open the floor again for our final Q&A session. And we are running a little bit over time, but the webinar is being recorded. So for those who do have an appointment to go to, you will receive the recording. However, for those who still have time, please stay tuned for the last Q&A session that we have. So I'll invite all the speakers again to join the discussion floor, and maybe I'll add some of the questions that have been posed at the very beginning of the webinar. So there have been some questions regarding size and how do you determine to what size you can still use FTRD. Do you have any algorithm? And there are people mentioning that MDT often rejects cases with lesions over 20 millimeters. How can they argue in favor of EFTR? Are there any recommendations that you have to define the size of the lesion? And maybe we can also discuss the hybrid technique in such cases.
Yeah, if it's okay.
Yes, please.
Yeah,
Go
yeah,
ahead.
yeah. So that's a good point. Well, the 2 centimeters is not a very strong cutoff. It all depends on the mobility of the tissue, the location where the lesion is. So you cannot say, oh, this one is 2 centimeters or maybe 21 millimeters. No, not possible. If it makes the big difference, if it has strong indication for the patient, I would really recommend to use the proof cap, because as already other speakers also show that, you know, if it's very mobile in the right-sided colon, it's easy to get pieces of 35 millimeter, even 4 centimeter out. So it's it all depends on mobility, and if in doubt, then use the proof cap to see whether it fits, and you'll be surprised that sometimes something looks really impossible, but then it's
But Barbara, I don't understand what you mean by saying use the proof cap. To see if you can get there?
No,
or if the lesion will suck in.
Yeah, exactly. If you would be able to get everything in the cap, to check for the mobility, to check for your success. It helps.
I mean,
better.
I find that to be a lot of work. You know, to have to go with the proof cap, go all the way there, come all the way back, etc., and reload. So what I do, I mean, just as a pragmatic thing, don't forget that the OD of the whole device is only, I think, 13 millimeters maybe. So I just use a regular cap on a therapeutic scope, and as like a basic way to look at things, and see if it sucks into the regular cap a little bit. Just difference in technique.
Yeah.
Well, the proof cap basically is just a cap that you place on your scope. So I think it's just either or what kind of cap you're using, but the approach is, I think, the same. Are there any other approaches, maybe from the other speakers, how you determine whether you can use FTRD and to what size?
I mean, you usually go up. You have to do the marking first, and you can go up with a scope with a cap on it, and mostly it's try and error. I mean, if you think it's too large, then I start with a EMR, with a hybrid EMR EFTR. Otherwise, As you said, Barbara, if it's in the part of the colon that's intra-abdominal and it's not attached to the retroperitoneum or somewhere else, you can get up to 4 centimeters resection specimens if it's been untreated. Otherwise, you have to turn to hybrid EMR FTR.
Okay. Maybe a question for Barbara. I'm interested in about the follow-up after an FTRD of T1 colorectal cancer who are not sent to surgery. So what's your follow-up procedure?
Yeah, that's a good question. So first, I take the opportunity of this question to maybe also put some comments on the scar resection, the follow-up of the scar resection, because we do this additional scar resection for an incomplete resection of a previous low-risk T1 cancer. But I think it's very important to stress the fact that it all depends on the initial histology. There were no risk factors present. And then you do the EFTR, it's a clean scar, and then you consider it as low risk. And we see in our registry, if the initial histology was completely burned material, like a very bad piecemeal resection, and pathologists cannot say anything on risk factors, it's not accessible, the initial histology, then be aware that, of course, those patients are at higher risk, for example, of having lymphovascular invasion at first sight that you couldn't see at the initial resection. So if you do a additional scar resection after this incomplete resection of histology that was completely shit, then be aware that the risk of recurrence is higher than, of course, there was some kind of histological assessment possible. So what we do after scar excisions with where the initial histology was really not accessible is we follow, like we say, more intense surveillance with yearly CT and also half-yearly CEA levels. So that's one thing. So don't think do scar resection, this patient was low risk, so let's just only do endoscopic resection. I think that's not safe enough. We need more data, and data will come. But I think that's one important point to make. And yeah, for the Dutch guideline, depth of invasion doesn't count as risk factor. So if we have a deep T1 cancer radically removed with good histology, without any other risk factors, then there's in at least in the Netherlands, we don't follow them up with CT scans. So it's just endoscopic surveillance. Yeah.
Barbara, can I ask you a little bit more about, risk factors? Because I was surprised that your high-risk lesions that you observed only had a 5% recurrence. Now, is that because, the follow-up was only 6 months in some of those? Were those 5 recurrences occurring in people who had been followed longer? And do you think it's just a function of not following them long enough? Or do you think that's a true result that will sort of be maintained regardless of the length of follow-up?
Yeah, that's a good point. So the average follow-up time was nearly 3 years. So we had there were also patients with 7 years follow-up. So there's not many cases with just 6 months follow-up. So I think it's a number that is that won't go up much higher than this 5%.
But did you parse it out to say you looked at your recurrences, let's say?
Yeah.
The recurrences of those have been only followed up under 3 years versus over 3 years. Did those recurrences tend to occur in the longer follow-ups compared to the shorter follow-ups?
I think the average recurrence.
I know the averages. I'm talking about dividing it between the short follow-up group and the longer follow-up group.
I can't give you the clear answer, but what comes up to me is that most recurrences came within the first 3 years. But there's not many recurrences that came after. But we know from data, of course, that the recurrences still, the other half comes after 3 years.
So. No, but your impression is that it was equally distributed. It wasn't a function of, this just wanted to get your impression. And the other thing is, we talk about lymphovascular invasion. Is there a difference between the lymphatic involvement and the vascular involvement?
Absolutely.
And the reason,
Absolutely.
So maybe you could talk to that a little bit, please.
So lymphovascular invasion is still counted like one risk factor, but there's a huge difference in large vessel invasion. So the venous invasion, which is which has very little risk of lymph node metastasis, but more risk of maybe distant metastasis. And then you have the small vessel invasion, so the lymphatic invasion, and that's the one that is determining the risk of lymph node metastasis. Absolutely. So if you only have a lesion with large vessel invasion, and I believe also many patients of our high-risk patients in the surveillance group only had large vessel invasion, so venous invasion, that risk is very, very low. So I think for the future I'm sorry.
No, please.
I think for the future for pathologists, it's so important that we make a differentiation. And that's why cooperation with a pathologist is so important. If you see lymphovascular invasion, go back to your pathologist and ask what kind of lymphovascular invasion. I mean, did you only see one cell in one vessel, or were, cells everywhere? Yeah. It makes such we don't know yet, but it must make such a big difference. And then indeed, was it small vessel or was it large vessel invasion? Yeah.
Yeah, because we noticed that in our group when we followed up our 35 cancers. Of the 8 who went to surgery and 7 had no cancer, 6 of the 7 had lymphovascular invasion, but they had no nodes and no residual cancer. Yeah.
Yeah.
I think if I might chime in, just a couple comments from our experience here as well. I think it's important that when you deal with a malignant situation, like whether it's T1 cancer or whatnot, that we also end up playing the role of the surgical oncologist, right? So it's not all just about endoscopic surveillance, but oncologic surveillance and following up with scans and whatnot, because there are imperfections within pathology as well. I think I tend to go to pathology quite often, and they'll tell you, hey, I don't know, how I'm going to write this report yet. I'm going to get your input, and based on your input, I'm going to write my report. To me, that sounds really scary. That sounds like, wow, I did not realize you had so much, so much uncertainty in how you're going to write your report, and I'm going to base my patient's long-term survival on your uncertainty in your report. And so, especially when we talk about large vessel, small vessel, lymphovascular invasion, there could also be differences in sectioning as well, right? If you have the right section, you might see the lymphovascular invasion. You don't have the right section, you'll miss it altogether. From our standpoint, we had a couple of cases where I think it's worth mentioning. I had one lady who we did an FTRD following a piecemeal resection of a T1 cancer, and the FTRD specimen was benign. So in other words, scarred clean, everything's good. T1 cancer, piecemeal resection. I followed her imaging for 3 years, and on the 3-year imaging, she was found to have a new 5-millimeter nodule in her lung. And that went to IR for biopsy, confirmed as metastatic adenocarcinoma, so an oligometastasis. She underwent a robotic wedge resection of her lung, and she's currently disease-free another year or 2 later. So, I think these are examples that go to show that if we start doing FTRD for malignant indications, that we have to kind of go beyond our role as endoscopists and as gastroenterologists, but start playing the role of oncologists, the surgical oncologists, and that demands that we also understand fundamental principles of surgical oncology and oncologic follow-up.
Definitely. But your patient had lymphovascular invasion at the initial piecemeal resection. Oh no.
Nope.
Yeah, but that's a good point, and that this is because the quality of the initial histology is after piecemeal resection always not good. So, and
right.
That is the
reason. This was like these are outside referrals. A lot of times I think all of us who work in the big ivory tower of academic medicine, these are referrals that come from outside pathologists, even our own pathologists. You get a young person who's like fresh out of GI pathology fellowship. It's not the same. There's a lot of variation. I think the longer I do FTRD, the longer I do endoscopic resection, the more I've learned how much variability is in pathology, how much variability is in radiology, how much variability are amongst my colorectal surgeons.
Yeah, absolutely. So for scar excision especially, I think it's crucial to do the surveillance well, and we need more studies. There's 2 studies coming up. I think there's a European randomized trial going on, surgery versus scar excision. There's the SCAR trial. And then in the Netherlands, we have already now running a couple of years is the prospective local trial, where indeed we do scar excision followed by intense surveillance. So yearly CT, half-yearly CAA, absolutely. We need to have more data before we can say scar excision is just, standard
And I mean, with
procedure.
regards to like intensive surveillance, I think quite frankly, we're behind as endoscopists because we're not trained in this way. But really, it's just as easy as following established guidelines. I don't know what you guys use in Europe, but in the United States, is established NCCN guidelines for follow-up of T1 or stage 1 colorectal carcinoma.
Yeah, as you can
The
tell
more
from
interesting
the
question that I have for this group, by the way, I want to pick your brains about this. Okay, so for stage 1 colorectal cancer, it's fairly well described what the follow-up is, right? I think we agree from a surgical standpoint, CEA, CT, endoscopic surveillance, etc., right? What do you do about neuroendocrine tumors that are low grade and that you find lymphovascular invasion?
There's nothing.
So I asked my oncologist this question. I'm at MD Anderson, so this is kind of like supposed to be like worldwide mecca of cancer, right? I asked my medical oncologist, clueless, no idea.
Yes, it seems that everybody is sort of clueless. As you can tell from the very engaged discussion, this is something that we could talk forever about. And I really appreciate the discussion going on. However, we have to have a look at the time, and also for the sake of you that still have
future
to
study.
yes. Future study, maybe. So I would like to thank everyone for the engaging questions and also to the speakers for their insightful answers. And as we are at the very end of the webinar, I would like to invite our co-hosts to share their key take-home messages. And I would like to start with Professor Caca with his concluding remarks.
Yeah, Bettina, thank you very much. I think it was a very interesting webinar, and I think we really come a long way with the FTRD system. And what most strikes me in all this presentation, that the results are comparable all over the world. Why is that? I think it's because the FTRD procedure it's rather easy. It's rather easy if you have a proper training. We are doing much more difficult procedures in interventional endoscopy and FTRD. It's quite easy. So FTRD in the lower GI tract, I think it's very established. I think the data on the T1 cancers are that much interesting because we want to spare more patients useless surgery. We used to accept like, okay, you've got a 20-30% risk of lymph node metastasis, so let's do a hemicolectomy. So I think this is probably not very appropriate nowadays, and I hope we will get over it. And I think the hybrid EMR EFTR is a little bit in competition with the colonic ESD, which is much more tedious from my point of view, but of course others would discuss it differently. And concerning T1 cancers, if you look at T1 cancers, they never look to ask the pathologist, they're never larger than 1 centimeter, so up to 1 to 2 centimeters. So they are really, really good candidates for en-bloc resection. For the upper GI tract, I think it's established for the subepithelial lesions. You have no other thing. I mean, the exposed EFTR, I think Dr. Nabi showed that this is more tedious and much more risky. And I think it will be interesting to see if we can come up with a first-line indication for the adenomas in the duodenum, whereas a study is running. So we'll see that. And I think what we haven't touched is motility disorders, which is an evolving field. And I think we will hear about this much more in the future. Thank you very much for Ovesco for giving me the opportunity to co-host this webinar. Thank you very much, Mark Schuer. Thank you very much, Bettina Schritzky.
Well, thank you. And back to New York to Dr. Haber.
Well, I don't want to, I think Karel summed it up very, very well as to where we are. And I think the future is very exciting because the ability to get the full thickness and to get great histology. And Barbara, you've done an amazing job with those studies to give us the sort of the courage to speak to our oncologic and surgical colleagues and show them the evidence that what we're doing is as curative as a resection for some of these more deeply invasive or more worrisome lesions. So I think that it's really morphed the entire field of endoscopic therapy of cancer. And I think we're very grateful to not only all these investigators who've done such a wonderful job, but to Ovesco for even putting together this forum for people to be able to have the dialogue and to talk amongst each other, and the whole business of lymphovascular invasions, of neuroendocrine tumors, et cetera. There's so much more we can learn. So I'm just very grateful for having the opportunity to participate, and I look forward to more of these. Thank you, Bettina, for all you've done for us and the whole team.
Well, thank you, Dr. Haber. We appreciate it. Also, it's all your work that made this happen and made it a success. So as we wrap up today's webinar, I want to extend a heartfelt thanks to all the speakers for their valuable contributions, and also to our audience for your active participation and questions. For those questions that have not been answered, you will get an answer afterwards. This webinar has been recorded and will be provided in the course of next week as a video on demand. We appreciate your time and engagement, and we look forward to continuing this journey of innovation and excellence together. Thank you for celebrating the 10th anniversary of FTRD with us, and goodbye to everyone. Thank you.